Hello, everyone.
Hi, everybody.
Welcome back to the Push Podcast.
Nice to see you again.
Yes, we're so happy you came back.
And Sydney and I are just slowly recovering today after a long few days for both of us covering labor and delivery.
Yes.
Sid, you've had quite an eventful few days, huh?
I have lots of work. My shifts have been very busy. Like the summer on labor and delivery is wild. There's always so much going on.
It is. Summer is special.
Yeah.
Summer, a lot of things are happening.
All the babies want to be born. New residence fellows starting in July, all that kind of stuff. So it's been busy, and also short staffed on the nursing side of things.
Yes. Well, summer, everyone wants to go away.
Everyone wants to go away. And unfortunately, we don't get a lot of vacation time. So it's, working with being short staffed is always fun. So
same. Yeah.
But we love our jobs. We love what we do. And it's been awesome. But we're tired.
We are tired today. We've both had a lot of late nights, a lot of long shifts, a lot of staying late. Both of us have stayed late, actually, a few times this week.
Yeah, I stayed late for my twins, but they came out beautifully. So I wouldn't have it any other way.
I've decided on a new tradition while I'm covering labor and delivery.
Yeah.
And I feel like it's brilliant. I've done it the last couple of times I've covered a day shift on the weekend.
Yeah.
I ordered pizza for the floor.
Oh, we love you.
But listen, it honestly brought up the whole mood. It was Sunday afternoon. Everybody was tired. A lot of the staff had been kind of in and around over the weekend.
Yep.
And we're all dragging our feet by the end as we're like approaching our Sunday evening handover. Yeah. And so I ordered pizza for everybody. We had a pizza party and it was so good.
Yeah.
And it was so much fun. I ordered all these different kinds.
Yeah.
And pizza is relatively inexpensive.
It is.
But like it's a cheap way to feed a whole floor.
Yeah, exactly. And food is the way to our hearts. Truly.
Oh, any prospective parents out there, food is our love language.
Yes. I actually had a patient drop off pizza on Monday and we were just so happy. Like it's the
kind.
best. Like especially when you're busy and you don't even have time to really like sit down and eat, just to like grab a slice of pizza. It's so good. And we love the OBs that we work with that order us pizza or food. It's just so nice. It is.
I told Steve when we went to the hospital to have Sam that we had to order something for all of the nurses afterwards. Like I could not let him embarrass me like that by not feeding the nurses. He did.
Okay, good.
He did. We ordered cookies though. We did cookies for everybody. We left kind of
Craig's
mid-afternoon.
Cookies.
So we ordered a bunch
Those
of
are my favorite cookies in the entire world. Man, I needed to still work there.
I know. Oh. Listen, this is also not an advertisement for Craig's Cookies.
No.
However,
I would love for them to sponsor.
Craig,
you know the amount of times I've messaged them?
Have you really?
I literally messaged them for my wedding to see if they would provide cookies for my wedding for like a late night because I love them.
They're so good.
Craig, if you're listening,
Craig, we're available.
We really want your cookies. We're available.
We would love to post up a box of Craig's Cookies right here that Sydney and I could snack on through the entire podcast.
For those of you who don't know, I'm pretty sure it's a Toronto brand.
It's a Toronto brand.
I think it's Toronto only. Yeah. So I'm sorry if you're listening in the States or whatever, but they are the best cookies ever. And they're far better than crumble cookies.
I feel like every city kind of has their cookie.
Yeah.
You know what I mean? Every city has their big, chunky cookie brand. Yeah. And a lot of places I think have like a big chunky cookie brand that's local to them. Yeah. And so this is our big chunky cookie brand and we're fans.
I also, can you tell I have a sweet tooth? Like I love cookies. I could eat them for breakfast, lunch, and dinner.
Oh man. So good. So good.
But speaking of food, I actually work with an anesthesiologist and if we do like a certain amount of epidurals a day, he'll order us pizza.
Really?
Yeah. It's really funny. He's like, if you keep me busy, you keep me working, I'll order you guys pizza. So, if it's a really busy day, he won't actually count them. Like if we're busy, he'll just order it, but he's great. And this is kind of a good segue into what we're talking about today, which is epidurals. Yeah.
Amazing. So, Sydney, what is your experience with epidurals as a labor and delivery nurse?
Yeah, I mean, I love epidurals. I also love unmedicated deliveries. So I'm very I'm all for epidurals as well. I think epidurals get a bad rap on social media too, especially. And a lot of people come in with the idea of, or their birth plan of, doing it unmedicated without the epidural just because they are scared usually. Mm-hmm. Usually it's a huge fear of the needle.
Yeah.
There's a lot of stories online of people like explaining their experience with the epidural or chronic like back pain associated with that, which we'll dive into today. But I will say, like, just quickly, my quick take on epidurals is I am all for them. Mm-hmm. I haven't had any babies yet myself, but I will most likely be getting an epidural when I have a baby, unless for some reason I go really quickly and can't have one, but that's very rare with your first baby. I would maybe like to try it with subsequent pregnancies and babies, but at least for my first, I'm really not against having one. I would probably wait a little bit just to see what contractions feel like and see how far I can go just for my own. That's kind of because I work in this area. I want to know what it feels like. Yeah. But I have seen epidurals be done. Oh gosh, how many? Like thousands, I feel like at this point. And they are a very safe procedure and they work really, really well. And honestly, they are a godsend for a lot of women in labor. And I can't believe that there was a time when they didn't exist.
Oh my goodness. I know. So having labored myself, and I'll echo what you've said too, in that I totally support a, unmedicated delivery. I've had some really memorable, really special unmedicated deliveries that I, reflect on in a really, heartwarming kind of sense.
Yeah.
I've also had some really wonderful medicated deliveries. And so I don't think that necessarily your route of pain management, whether it happens through an epidural or through, breathing techniques or meditation or any of the other methods of pain management in labor, really dictates necessarily in and of itself how your labor goes or what your experience is. But for myself personally, I am certainly a big fan. I was a big fan of my epidural.
Yeah.
A big fan of the resident that put it in as well. She did an amazing job in what I can only imagine was a very high pressure epidural.
Yeah.
But I still found that I learned a lot in researching for this episode, and it was cool to kind of dig into some more of the evidence around how they work and why they work and what some of the risks and benefits of them are.
Exactly. And, to start this off, we want to also say we're not anesthesiologists. So anesthesia, that's a hard word to say. Anesthesiologists are who insert the epidurals. So, I'm a labor and delivery nurse. I assist with the epidural procedure with handing off sterile equipment, making sure the patient's in the proper position, getting all that kind of stuff ready. And then I'm sure from your side of things, being an OB-GYN, you're also familiar with epidurals and everything, but
I mean, honestly, not really, because I'm not even in the room.
That's true. That's true. Yeah. That's a very good point. It's true. You're never there. I mean, ever.
Sometimes I'm in the room for the spinal. Often I'm in the room for the spinal if we do a C-section.
Yeah.
But I am often not in the room for the epidural. In fact, many times I'll knock on a door and come in to see a patient and see that they're getting the epidural, and I circle right back around and leave
because you don't need to be there.
Well, and there's no point in me putting a patient through an exam or talking about anything with respect to their care or making, management, like shared decision making for their management because they're busy.
Yeah, exactly.
So truly, it was a new experience for me to have my own epidural.
Yeah.
In spite of having a lot of outside familiarity, I really had very little experience in that moment of what that looks like.
Interesting.
Until I went through it myself.
Yeah.
But before we get too deep in the weeds of our own experiences and kind of what we've seen, it's probably good to circle back or to roll it back a little bit and talk about what an epidural is anyway.
Yeah.
Right?
Yeah. What's in it? What is it doing? Why does it work?
Exactly. Because the thing is that even as you're getting one, you're not seeing it happen, right?
Yeah.
By definition, it happens behind you. And so we'll delve into a little bit of what the clinical explanation of it is. So epidurals basically fall into a category of pain control techniques called neuraxial anesthesia. And I should, echo your preface as well before we get too into this, that I do As much as I joke that I don't know a lot about the epidural because I'm not there. I do actually have to understand. I've had to understand the basics of the medicine of epidurals for my Royal College
You are a doctor.
I do know the medicine of the epidurals, even if I don't get the privilege of kind of guiding patients through them very often.
Yeah.
But certainly anesthesiologists, if you hear me say anything that you disagree with, or if you think there's a little bit more nuance to any of the discussion, please chime in. We would welcome that perspective.
Absolutely. If you want to come on the podcast too, let us know. We would love to have an anesthesiologist on here for sure.
So usually what is in an epidural is a combination of a local anesthetic as well as an adjuvant, usually opioid medication for pain control.
Yeah.
And basically how it works is by blocking the signal of pain at the level of the spinal cord. Now, in order to understand what that really means or how it impacts your experience of labor, I think we have to go back to the basics of pain in general and what that is.
Yeah.
Pain, by definition, is kind of all in our heads, right?
Yeah.
I think that term is often used as almost an accusation to suggest that people are imagining pain, but truly pain is controlled by our brains, and it's a means to tell us what is dangerous and what is not.
That there's something wrong.
Exactly. So I once had an anesthetist explain it to me like this. Imagine you touch something hot, right? Like a stove. Your hand sends a signal to your brain saying something is wrong. But that feeling of pain actually doesn't originate in your brain. Or rather, it doesn't originate in your hand. It originates in your brain. Your brain creates that sensation and sends that message back down to your hand in order to make you stop what you're doing to protect yourself.
Yeah.
Right?
Yeah.
So pain is kind of a constant discussion between the different parts of our body and our brain, which interprets the information and assesses overall risk to our bodies.
Yeah.
This system of pain and of this message translation happens kind of along two main pathways in the body, the peripheral pain pathway and the central pain pathway. So the peripheral system is really where the stimulus for pain often first occurs. Our skin, our muscles, our joints, and our organs are all full of tiny little sensors, basically, that detect danger. And danger can take the form of things like heat or pressure or an injury. When you say stub your toe, these sensors send an electrical signal through the nerves in your foot and leg. And these nerves are part of the peripheral nervous system, and that's the network outside of your brain and spinal cord. These signals then travel quickly up to the nerves in your spinal cord. Once they reach there, that place, it's handed off to the central nervous system, which includes the spinal cord and the brain. And that's kind of like the main highway, the interstate of all of this. Whereas the peripheral nervous system is perhaps like the little country roads, right?
Yeah.
The spinal cord then acts kind of like a relay station, and it can either pass along a message, block it, or even amplify it if they think that the risk or the danger is significant.
Yeah.
If the message goes through, it travels all the way up to the brain, and your brain then interprets that signal as pain.
Yeah.
It decides how bad it is, whether you should move, whether you should cry, whether you should be afraid.
Yeah.
And the brain then sends signals back down to either amplify the pain, like calming it down, or dampen the pain rather, like calming it down with natural painkillers, or making it worse, especially if you are anxious or stressed. So obviously when you're in labor, your body is doing something super powerful. You're getting ready to deliver a baby. But that process puts a ton of pressure and stretching on your muscles and your organs and your nerves, especially in the lower part of your body, right? Where your uterus, your lower back, and your pelvis all are.
Yeah.
All of that pressure and movement sends pain signals through the peripheral nerves, right? The same pathway that we just talked about. These nerves then carry the signals from your uterus and lower body into your spinal cord. And then your central pathway carries these pain signals up to your brain. Your brain interprets all of that as pretty intense pain, especially during that kind of acute moment of contractions. Yeah. So an epidural works like a roadblock on that pain highway. So the doctor places a tiny tube in your lower back right near the spinal cord in a space called the epidural space. Through that tube, they then give a numbing medication that affects the nerves coming from the lower half of your body. So that medicine basically blocks or dampens the pain signals before they can reach your brain.
Yeah.
So your body is still doing all the work of labor. It's not impacting the muscles themselves.
No.
But your brain isn't receiving the full blast of that pain signal. So it's kind of like turning down the volume on the loudspeaker from your lower half.
Exactly. That's a really good way of putting it.
We have a couple of different ways that we can do this as well. That you've probably heard about. An epidural, which we kind of use as like a catch-all, I think, for this type of neuraxial analgesia, often when we're talking about them commonly.
Yep.
But there's also a spinal, which is a little bit different.
Yeah.
So a spinal is a one-time injection directly into the fluid that's directly around the spinal cord. It works super quickly, usually within a few minutes. But it is just, again, a one-time injection, right?
Yeah. So nothing stays in your back.
Nothing stays in your back. And so we use that usually for C-sections or very quick procedures.
Yeah.
An epidural is placed just outside of the space.
Yeah.
And a tiny tube is left in place so that you can get continuous pain relief over a longer period.
Yeah.
Takes a little bit longer to kick in. But that's what's often used for the process of someone's labor, right?
Yeah.
Because a spinal isn't necessarily going
to...
It's like
2 hours, I think, is the...
Yeah.
Like, I mean, a bit longer, but 2 hours of effective pain relief. So it's not that
more
long.
on the realm of a few hours as opposed to like,
potentially
12 hours, 24 hours, 36 hours, which is really what we need for the process of labor potentially.
Yeah, exactly.
We also can do sometimes a combination of both called a combined spinal epidural to get fast relief that also lasts.
Yeah.
So Sydney, how do you explain this to patients in real time? And what do you find is the understanding that people come into the hospital with respect to this type of pain control?
Yeah. So I think a lot of people think that a lot of people, first of all, don't know that an epidural is actually something that you keep in your back and it's a continuous infusion. I think a lot of people come in and think it is the spinal, which is just a shot in your back.
Yeah.
I don't know if that's just because you hear, an epidural needle's really big, all of that. They hear that, but they don't really think, so I almost explain it as similar to an IV, that when you get an IV put in, it's continuously accessing your bloodstream and giving you medication, fluids through that port.
Yeah.
It's similar to the epidural. So what the actual needle that they use for the epidural is only used for the insertion. After that, they use the needle, then they put the epidural catheter, so the little tube in, and then once they get it in the right spot, we just tape it all up. They take out the actual needle, and then I just secure it really, really well on the back so that it's not going to move at all.
Yeah.
And that way you can actually lie down. So that's why you can completely lie down flat on your back. You
can
move side to side. You can do a lot of things with an epidural because it is in the epidural space and there's no needle. So a lot of people are really scared to move around, and you don't actually have to be. It's completely safe. It's actually made so that you can move around, and so that you can continuously get medication all the way until the baby is born. So a lot of people think, if I get the epidural too early, it's going to wear off and all these things. And actually, it's going to give you medication all the way until baby's born. I mean, have I seen some patients who have less effective epidurals at certain points, or they feel like maybe it's wearing off at certain times? Yes, epidurals aren't perfect. They're a great tool that we have, but they're not going to take away 100% of the pain that you're experiencing. Epidurals are really good for sharp pain. So, if you were to take a needle and press on your leg with an epidural, you're not going to feel the sharp pain of the needle, but you are going to feel the pressure of the needle going into your leg. And I think a lot of people think they're just going to be completely immobilized and not be able to feel anything at all. And that's actually not true. You will feel things, and that's so that you can actually push your baby out. It's actually really beneficial when you can feel a little bit, even though sometimes that pressure can be almost painful, right? Like it can be very intense. It's also hard to define this because everyone's different and everyone's experience with epidurals is different, depending on the dosage, the anatomy, all that kind of stuff. So you might have one epidural that works exceptionally well that completely numbs you and you didn't even feel pressure, which is called like a really deep, like strong epidural, or a good block is what we call it. Whereas you might have a lighter block that actually, you know, you can completely move your legs and it feels lighter, but you're not feeling that sharp pain. So it's everyone's different. It just depends on, again, the type of medication, how much they're using, the dose, all that kind of stuff. But I think that's the main differentiation that people get confused, is that, you know, there is something that is continuously giving you medication versus the spinal but
it's not a needle. And I think that is a super good point to bring up, that the needle doesn't stay in, because I've often found as well that people even get confused with IVs, thinking that the needle stays in an IV, but it's just the tubing. We use the needle in order to find our way into that space, but then a tube is threaded over, and then that's what provides you with medication, fluids, things like that, even with just a standard venous puncture.
And I've had some people be like, but it hurts like there's a needle in there. And I'm like, it's irritated. I mean, it just had some, like there's a foreign object in the vein. So it's irritated. But there's no longer a needle there, which is a big misconception. You're so right. Yeah.
So what does the setup look like, Sid? As somebody who has like acknowledged that very few epidurals I have actually stayed for in the room outside of my own epidural. So what does it look like? Like, I'm a laboring person. I've just said, you know what? I'm ready for my epidural. What does that process look like from your perspective?
Yeah. So if someone is ready for the epidural, I usually just have to call the anesthesiologist who's on call. Certain facilities have anesthesiologists that are designated to labor and delivery. These are usually larger facilities. Because you have to have like a certain amount of births per year to actually get a designated anesthesiologist, whereas most facilities have a couple anesthesiologists who do the whole hospital. So you have to call them and be like, hey, I have a patient here. She would like an epidural. When are you available? And then they'll usually give you a timeline. They'll be like, oh, I can come up in 5 minutes, or, oh, I'm finishing up a case. Like, I'm going to be about 30 minutes. Sometimes it's very busy and it's much longer. But I would say on average, it's usually between 5 and 30 minutes that they come up and complete the epidural. So once you've decided you want it, I've called them. I usually explain the procedure ahead of time to my patients. So I'll just give them an overview, even though the anesthesiologist still kind of does that. I feel like it's nice to kind of get an idea.
Get a primer.
Yeah, exactly. And, you know, sometimes we'll even practice the positioning ahead of time, which is, you know, you may have seen online, but it's kind of like you hunch over into this almost like your texting position with your shoulders really relaxed and your back really curled around the baby as much as you can. It's a very uncomfortable position for someone who's like 9 months pregnant. It's not it's not ideal. It is not ideal. I recognize that. And it can be challenging, but it's usually pretty short-lived. And we usually sit you on the side of the bed with, you can do like a crisscross applesauce with your legs if you're able to do that, which most of my patients can't when they're 9 months pregnant. But if you can, that's a great position. Or you can put your feet on like your partner. If your partner's sitting right in front of you, you can put your feet on them or on a little stool, or just have your legs dangling. And then you can also like hold onto a pillow, or me, like sometimes I'll stand in front of my patients and they can just hold on to me throughout the epidural. Or I'll like keep my hands on their shoulders to kind of keep them relaxed and low. Cause when you're tense and you're nervous, you tend to like scrunch up your shoulders up to your ears, and sit up really straight. And that's the worst possible position for an epidural. You want to really curve out that lower back so that your spinal bones kind of open up so that they can get into that epidural space. So that's kind of the positioning, and you know, we go over that ahead of time. Usually I'll take my patient to the bathroom too if they haven't gone to the bathroom recently. Sense. Yeah, just because it's going to be a while before, you know, you can empty your bladder on your own. And then I bring in the epidural cart. So usually most hospitals have a cart that has all of the supplies in it that we'll need for the procedure. And we just do the epidural in the patient room. So it's not like we're going to like the operating room to do an epidural. It's just done in the room. You don't need to leave the room. You can usually have one person with you in the room, not more than that, only because it is a sterile procedure. So we don't want to have tons of people in the room. And We tend to get a lot of fainters who watch epidurals be placed. It's a stressful situation, and watching it is not it's not something you see every day. So, no. Grandmas, I've had grandmas pass out, baby daddies all the time. Oh yeah. So even if you think you're going to be fine, we usually say sit down, or leave the room, because it's just, it's a sterile procedure, and it's better. Yeah, we don't want to have 3 patients instead of 2. The mom and baby
We always say that anytime there's any procedures or things that could be happening where people might be getting a little squeamish.
And it's always the 6-foot males who are covered in tattoos, and they hit the ground.
The toughest men. Yeah.
Which I think is so funny.
sorry guys, but you got to admit the contrast of that. It's pretty humorous.
It's so funny.
But please don't faint, and we don't want you to faint. No, we don't want you to hurt yourself. Big or small.
I've had some situations where we've had to send dads to the emergency department.
Yeah, I've had that too. Yeah.
You don't want to have to miss the baby's birth because you're in emerge for a concussion. No. That's not an ideal situation. So always sitting down, but they can still stay in the room as long as they feel comfortable. If that's not an option, then you can bring we can bring another nurse in as well to help, but and then we have all the supplies. We usually give you a little hairnet or mask or both, and then
just because it is a sterile procedure, right?
Exactly. But other than that, that's pretty much it. The first part of the epidural, I would say, I haven't experienced it, maybe you can speak on this yourself, but I usually say the first part's the worst, which is the lidocaine injection, which is the freezing that freezes just the skin. That kind of feels, I've been told, feels like a bee sting. Would you say that's correct?
You know what? In reflecting on my epidural,
do you even remember?
What I think was really true, that I think I've heard, or I must have heard providers tell patients as I was training, was that if you do wait until your contractions get kind of to your peak of intensity, whatever your own barometer is, before asking for the epidural, then the pain of the epidural is the least of your concerns. And I would have to say that's right. I'm sure I would have been nervous for the epidural, even being an OB-GYN, knowing, just because it's a procedure. No one is completely still faced in the face of discomfort, right?
And it's hard I feel like it's hard to stay still too. That would be hard for me.
Yeah. So I was like you, actually. I was induced, which we can talk about in a future episode in a little bit more detail. So I was on oxytocin. I'd had my water broken. I was contracting away. My contractions really ramped up very fast. And so when I asked for the epidural, it kind of caught me by surprise how intense my labor got, because it really happened very quickly. And at that point, again, it was really true. I was so much more focused on the contractions and breathing through them than I was the pain. It did not even make a dent in my memory. The pain of having the epidural inserted.
That's how you know that you got the epidural at a good time, I will say, because if you're in that much pain, you know that it was a good decision.
It was a good time. You know what I didn't care about when I got my epidural said was how far dilated I was.
Fair.
And I find that is a question or a presumption, I think, that a lot of my patients have. They often ask me, when can I get the epidural? And I tell them I have had epidurals inserted at 1 centimeter dilated or no centimeters dilated. I've had epidurals inserted at 10 centimeters dilated. There is no dilatation requirement.
But that's a question that everybody asks.
Well, and I think it's probably a vestige of older practice. But the truth is that now, since 2019 even, so for the last 6 years, the American College of Obstetricians and Gynecologists actually has very strongly stated that the decision to get an epidural to initiate neuraxial analgesia should not be based on arbitrary cervical dilatation thresholds. And the reason for that is because we have good data to suggest that it doesn't matter.
It doesn't matter.
No, there was a good Cochrane review in 2011. And I feel like anyone who listens to a few of our podcasts by now will probably have heard me mention Cochrane reviews before. They're one of our highest level of, I'm not paid by Cochrane, by the way. I haven't even been involved in a Cochrane review. They're just very systematic reviews. and meta-analyses that look at lots of different studies. They amalgamate the data.
To.
Exactly. Mm-hmm. They amalgamate the data between multiple different studies through very stringent, very transparent rules to provide us with some of the best kind of quality evidence that we can.
Yeah.
And so there was a 2011 Cochrane review that, as part of the review, looked specifically at the timing of epidurals. And they found no increase in C-section rate and no increase in operative vaginal delivery, so forceps or vacuum, when epidurals were started earlier in someone's labor process versus later in someone's labor process. So getting an epidural early is not going to change your outcome one way or the other. Let your own pain thresholds, let your own feelings of independence dictate when you need the epidural.
Yeah. And something I always tell my patients is it's less so about when you get the epidural and how dilated you are, but more so like, especially if it is your first baby, this is probably going to be a long process. So you have to know in your brain what feels right for you and how long you want to be bedbound, because when you have an epidural, you can't, unless you're in an area that does walking epidurals, which is not very common, but you're going to be in bed. Like it's not safe to get up. So I think that's something to more keep into consideration, is if you're feeling okay and you're coping well with the contraction pain that you're experiencing, and you're early on in your labor and this is your first baby, I would say wait it out for as long as you can, only if you care to be out of bed. So if you're going to be in bed either way, there's one thing about being in bed and suffering, or being in bed and being pain-free, right? Yeah. So if you're going to be up and walking around and going on the birthing ball and all these kinds of things, wanting to go in the shower, all of those things, then, getting an epidural at 0 centimeters dilated wouldn't really make sense for you.
Well, it's not in keeping with those goals, right?
Exactly.
If that's a goal that somebody has.
But if you don't mind and you just want to rest in bed and watch movies, that's totally fine.
I usually tell my patients, when they feel like the pain control that they're going to gain is worth giving up the independence by not being able to move around, then that is an appropriate time to get an epidural.
Exactly.
It's funny. I had seen, I think, one of your nurse influencer friends, and I wish I could remember who it was, because I would love to kind of give them credit for this, but posted recently about epidural being insufficient as like the only element of someone's pain control strategy, right?
Yes.
And I totally agree with that. I think that like we have to have a wider arsenal at our disposal to manage pain in labor. Not that like I'm happy if every one of my patients wants to get an epidural, no problem. But in my own labor, for instance, I was woefully ill prepared from that perspective, because I was just busy with other things. And I think you just kind of take for granted that you know what this process looks like. Yeah. And when I asked for my epidural, all of the anesthetists were busy in cesarean sections. So no one could come. And
as the nurse, I hate that too, because I'm like, I can't give you what you need.
I remember thinking, okay, I've seen this on TikTok. I've seen this, I've seen my patients do this.
Yep.
I'm going to get up. I'm going to move around.
Yep.
I got up by the side of the bed. I put my hands on the bed. I got Steve to put pressure on my back. I tried to get on a ball. I did all of these things. And truthful, if I'm being honest. The pain was bad in every position. It was bad.
But that's how you know you were in active good labor.
But you know what? It at least passed some time. And I wished in that moment that I had done more, education myself on how to manage my own pain, how to cope with my own pain in labor. I think I coped okay. I hope I didn't embarrass myself with my my pain threshold in labor. I say that jokingly. Truly, you can't. Everyone deals with this differently.
Exactly.
And that's just
differently, but at the same time, the same.
Yeah.
In a weird way.
Yeah.
You just turn into this animal.
Yeah. Fair enough. It's
Most women
primal.
do, at least.
It's very primal.
But
While we're talking about timing, though, the other thing that I have often heard is this idea that getting an epidural slows down your labor process. And I would say that the evidence is a little bit mixed on that. So older observational studies did find potentially that there were some slower times to delivery, but more modern studies have examined this in a little bit more of a nuanced fashion. Back in 2005, there was a study published by Wong et al. In the New England Journal of Medicine, which is one of our biggest medical journals. And it was a randomized control trial that looked at early versus late epidural initiation. So either at less than 2 centimeters or greater than 4 centimeters. They examined 884 women. So pretty big patient sample. And they actually found that the duration of the first stage of labor, so 0 to 10 centimeters, was approximately 90 minutes shorter in the early epidural group as opposed to the later epidural group.
Okay.
Now, there's a 2022 review. So again, like a much more up-to-date review, almost 20 years later, that found somewhat a bit the opposite, that an epidural may extend the first stage of labor by approximately 30 minutes, but certainly found very strongly that it doesn't impact overall outcomes one way or the other.
Yes.
And I think really the thing to keep in mind with this is if we're really digging into this data, and there's a lot to be said in critical appraisals of both of these studies as to like what their strengths and limitations were. But if we're really debating kind of 30 minutes one way, 90 minutes the other way, in a process that can sometimes take, again, 12, 24, 36, 48 hours. I think that we're really looking at the minutia. And that's not to say that that isn't important for us as providers to try and suss out. But I do think from the perspective of somebody choosing for themselves, I hope that that alleviates concern that there is like some huge extension of your labor process if you are going to get an epidural. Because certainly, I think I would hazard a guess that researchers on both sides of that debate would confirm very strongly that it is not going to extend your labor by hours and hours.
And like it is 6+ hours.
And it is not going to impact whether you have a C-section. It is not going to impact your overall
Which I think
outcomes.
that in itself is honestly the more important part. I will say from like my own clinical practice, this is my own evidence. This is not. But I do feel like it does slow things down. I will say that ever so slightly, not to an extent that it matters. Like you said, I will say I have seen unmedicated births that are also have potentially stalled and in the second stage too. So it's hard to compare, but I will say that, I do notice a lot of the time a pattern of, you get the epidural at, let's say 4 centimeters dilated, let's just say, you're starting to get into good active labor, you get the epidural, and then your contraction pattern peters off. I don't know if that's something you've also seen, but that's usually when you would say, let's start oxytocin, let's start Pitocin.
I've seen that, but I would also argue that I've seen the opposite happen too, right? I've seen people really perseverate with unmedicated deliveries and we're just not getting anywhere with their cervical dilatation.
And then they relax with the epidural.
They relax with the epidural and then suddenly they go from 6 to 10 centimeters and we're in business. So
it's so true. So it's hard to pinpoint if it's the epidural or not, because it's very patient dependent.
Totally. Not to be the devil's advocate, but I would actually argue
be the devil's advocate.
I would actually raise an argument to the contrary. Not to say that that's not correct. I've also seen that, right? Where the contraction pattern peters out. But I've additionally seen where somebody is really perseverating in early labor, right? Especially early labor. They've been unmedicated. They're super tense. They've been sitting at like 5 centimeters for hours and hours. And then finally they decide it's time for the epidural. They totally relax and we blink and they're 10 centimeters an hour later. So
true.
Right?
I've also
seen that countless times.
Yeah.
And so I think all that to say, it is a really individualized experience and a really individualized decision that should be taken with shared decision making between the providers involved in your care. But most importantly, the patient themselves, right? And what's important to their experience and what they feel is right for their body in that moment. But there's what I would like to hopefully relieve people of in the context of making this decision around the idea of things like slowing down your labor or needing to be a certain, amount of arbitrary dilatation is that you don't have to expect any of those things, right? Like you can choose to have the epidural in accordance with what you think is right for your particular labor as it unfolds, right? As opposed to feeling like it will necessarily do that for you.
Exactly. Right? And I think that's a great point is just to keep keep an epidural as it's a tool in your toolbox that we can use. And we also have other tools we can use if we need to use them. For example, if for some reason you get the epidural and your contraction pattern slows down, there's things that we can do to help things move along. Or the opposite, you've been sitting at 7 centimeters dilated for hours and hours, and you're no longer coping. You are suffering, and things are not progressing. There are tools we can use, like the epidural, to relax you and dilate you to fully dilated, so that you can push your baby out.
Sometimes epidural is a solution, even when it's not necessarily only about pain control, at least from an anecdotal perspective.
I will say that, like, having other tools in your toolbox, like, practicing maybe some hypnobirthing meditation, using other things like, I don't know, seeing what your hospital offers, sterile water injections, showers, like hydrotherapy, all these kinds of things are also really, really good to familiarize yourself with ahead of time. But I think that the epidural is villainized a lot of times, and it doesn't have to be, right?
No, absolutely not. And take it from me, the middle of your labor when you've asked for the epidural is probably not the best time to be like hopping on YouTube to look at what counter pressure should look like.
Exactly. Like,
or trying to educate your poor husband in that context to now provide you with pain relief when you are already in the throes of it.
That could be like my biggest advice, is to just like try to prep a little bit ahead of time 100%. On these things, because it's going to help you in the moment.
For sure.
Right?
I think that's only helpful, right? Even if your plan is 100% epidural. Now, epidural is a tool, but as with any tool, right? Medical or, adjuvant. Adjuvant's not the right word. Complementary.
I don't know what adjuvant means, if I'm being honest with you.
Right? It's not without side effects, right? Common side effects that we see with the epidural, very, very commonly we see kind of like a sudden drop in blood pressure. Right?
Yes, that one we see very often.
We can see nausea and vomiting associated with the epidural, usually actually because of a transient drop in blood pressure.
If your blood pressure drops, you usually start to feel queasy. Like goes hand in hand.
And to be clear, this is not a drop in blood pressure that threatens your life, right?
No,
but again, it can make you feel pretty crummy.
And we reverse it pretty quickly with medications, or fluids and that kind of stuff.
Exactly. Oftentimes people have difficulty peeing because of a decreased ability, I think, to sense a full bladder, right? Which is neuromuscularly mediated, but also to a decreased ability to initiate the muscle activation that is needed in order to void. And so for that reason, oftentimes we need to use a catheter to help you pee during your labor once you have your epidural. And then the other one as well, I think, just in the realm of like fairly benign side effects, is shivering.
Oh, that's a big one.
Super common.
Almost everyone experiences
that.
But I will say too, you will kind of experience that sometimes even without an epidural, just from labor in general. So
absolutely.
It's your body's reaction to all the hormones and the stress and shock. But
my understanding is that the mechanism is pretty poorly understood. But it's thought to be perhaps because the epidural drops your blood pressure, you get some vasodilatation. So widening of the blood vessels to try and distribute blood to all of your organs. And your body may sense that as kind of like a draw of blood away from everywhere. And so it's the shivering may be an attempt to like redistribute heat through your body.
I've heard that as well. A lot of my patients will be like, I must be so cold, but it's not actually temperature related in that sense. Like, you don't need to be covered, because sometimes I'll walk in and they'll be like in a winter jacket with 5 blankets on them. I'm like, you're gonna get a fever. Don't do that. And they're like, but I'm shaking so much. And it's like, that's just a side effect from the epidural. It's not harmful. It's not dangerous. It's just annoying.
Now, as far as the risks associated with epidurals, I do think the most common risk is one we've alluded to, but perhaps one that people are not really thinking about when they're worried about risks of epidurals. And that is inadequate pain control, right? It is a really good tool. But it's not that uncommon that people have a block that is perhaps unbalanced, so you're still able to feel it on one side, or that it's not quite sufficient enough to completely control your pain. And when we look at the data, that does seem to happen between 3 and 12% of the time, depending on the study.
Yeah.
And so not that uncommon. Now, again, there are solutions to that, right?
Yep.
We can top up your epidural, we can recite it.
Yep.
And the troubleshooting of this would be a really interesting discussion with an anesthesiologist, because the truth is that I just call anesthesia when we're having epidural problems.
Yeah.
But we are often able to find a solution for inadequate pain control.
And
exactly.
They work a bit by gravity too, which is interesting. But it kind of, so if you've been on one side for an hour, you might start to feel more pain on your right side, if the side that's up versus your left, and all the epidural will almost pool in that leg. So the solution to that would be to flip you, right? Yeah. So that's why it's also important to continuously move and to not be also sitting straight up either. Because then it will decrease. It'll go down to your toes instead of where you need it. So
now on that note, we can have blocks that are too high.
That's
right.
Exactly. That's also a problem.
And don't give you enough mobility, right? So blocks where you're not able to move your legs. And very, very rarely blocks where we might start to worry about your breathing if the block was in fact too high. Now, again, that is not a common circumstance.
Not at all. Not at all. It happens, but it's not common.
No. Something that I see that is really, I think, bothersome for patients when they experience it, although still rare, that we have probably both certainly seen and taken care of patients who've been implicated or impacted by this, is something called a post-dural puncture headache.
Yes. Yeah. Which does happen. Not, again, not something super common, but it does happen.
Yeah.
And usually the anesthesiologist will be able to tell you if that is something that you may develop or not, depending on how the procedure actually went.
So the dura is the tough layer that lies directly around the spinal cord itself. And a post-dural puncture headache is a positional headache that occurs because of leakage of fluid through that dural puncture site. The incidence of it is about 1%. And the vast majority of that 1% resolve on their own.
Right? Yeah, they don't need anything.
And so they don't need anything else. Very severe ones may rarely require a procedure called an epidural blood patch in order to kind of block up that area with your own blood cells, actually.
Yeah, it's I've actually assisted with only one. So it's not very many considering how many epidurals I've seen, but it is a very interesting procedure, but it's basically an epidural, but they just take your blood and then re-inject the blood into the epidural space where that dural puncture is. But they work really well too. So
now, we wouldn't be a transparent podcast if we didn't talk about the rare severe consequences of epidurals, right? And so I definitely don't want to fearmonger, but I also do want to be open about the fact that there are people who have experienced severe complications from epidurals, just like any medical procedure.
Yeah, and even before we move on to those, even the dural headaches, like the dural punctures, they can be very uncomfortable for patients.
Yeah, they can be super uncomfortable.
Hard when you have that and you just delivered a newborn baby. And usually if you sit straight up with a dural puncture, you get that's when you get the really bad headache, is when you're sitting up or standing. And as you can imagine, that's very difficult after you've just delivered a baby, not to be sitting up and standing. So, anyways, it's very rare, but it does happen. And I recognize that it is not a fun experience, but
totally, we
have to talk about these things, right?
100%.
Nothing good comes without risks.
No, this is the thing, right? So as far as the big bads, spinal epidural hematomas are definitely a concern, which is basically an internal bruise of blood. They can be very severe and have severe consequences for people's motor and neurological function. But the good news is they're extremely rare. So based on the U.S. nationwide inpatient sample of over 2.3 million obstetrical epidurals, the incidence of epidural hematomas was only 0.6 per 100,000. And so what that means is less than a 0.01% chance of having this happen.
That's very rare. I've never
very
seen
rare,
that
and obviously more of a concern for people who may have bleeding disorders. For reasons why their blood may not clot or may pool a little bit more than other people who are more hematologically.
Which is why it's important that we also test your blood before the epidural. So we usually like to know your platelet count and all that kind of stuff before we actually even give you the epidural to make sure your clotting factors are good and all that kind of stuff. But anyways.
Exactly. As far as postpartum nerve injuries, because people obviously, I think, worry a lot about the idea that something is around their spinal cord, right?
Oh, yeah.
That makes us super stressed.
Of course.
Again, there have been documented nerve injuries from epidurals, but they are so rare that we have no data for them.
Yep.
So it would be really difficult to guess at the incidence, certainly less than this 0.01%. Now, I think it's also important to reflect as we're talking about these risks that in some cases, the data that we're sampling is not just obstetrical, right? Because spinals and epidurals are used for a lot of different procedures and surgeries and areas of medicine outside of the obstetrical practice.
Yeah, which not a lot of people know either. I feel like most people think you think epidural, baby, having a baby. But they're used commonly for all sorts
of different kinds of surgeries. Exactly.
Fun fact, my dog got one when she had her knee replacement.
I
know. She had a little patch on her back with they had to shave her fur right on her back. It was so cute.
So sweet.
Poor Ivy. She's good now though.
So we have data from, we're pulling from more than just obstetrical care when we're trying to assess these risks. And then the last thing to talk about is risk of infection. So again, this is something from outside of the body that we're putting inside of the body. And anytime we do that, there is a risk of infection, no matter how sterile the procedure is. Meningitis is a super serious infection that's associated with epidurals. But the incidence, as best as we can guess, is in the realm of about 1 in 40,000 or so. So again, very, very rare. Now, with respect to risks to baby, people also always ask me, is this going to harm my baby? And the good news is that most fetal effects that we see on the fetal heart rate monitor are actually due to, circling back to just the side effects, a drop in maternal blood pressure.
Always.
And so oftentimes if we get a sharp drop in someone's blood pressure after the epidural, we may get a drop in baby's heart rate that is transient, and not associated with long-term neurological outcomes or even with the overall outcome of their labor. So usually it's very dramatic. Everybody runs in the room. We reposition mom. We check to see whether or not the uterus is contracting. We check the blood pressure and sometimes have to give some medications to bring it back up. But then things, 99 times out of 100, that's not a real stat. That's an anecdotal out of my brain stat, but almost always it's fine. It just comes back and we cruise
we
through
call
labor
them all the time post-epidural dips.
Post-epidural dips.
That's a thing that we say to each other. It's common. It happens. We anticipate it happening and we do things to hopefully prevent them from happening as well. So making sure that we give a patient fluids, if they're dehydrated, we give them fluids beforehand to help maintain their blood pressure. We also don't, as the nurse, we don't put the patient super flat on their back right after the epidural as well, because obviously when you're pregnant, it's not good to be super flat, and that will also decrease your blood pressure. So we usually tilt you a little bit with a wedge onto one side or another just to make sure you're not super flat, because that will also contribute to your blood pressure dropping and therefore the baby's heart rate dropping. But like you said, 99% of the time, if this happens, we correct it, the baby recovers, and babies are made to withstand a certain amount of stress.
Labor is inherently stressful.
Exactly.
And babies are built to sustain it for the most part.
Yep.
The good news as well is that, again, when we look at big data, epidurals, even those that cause post-epidural dips are not shown to be associated with any adverse neonatal outcomes and any associated need for emergency cesarean deliveries when we look at the big numbers in the data as compared to people who did not have an epidural. And interestingly, I actually found that in the absence of a drop in maternal blood pressure, epidurals actually have been shown to improve intervillous blood flow within the placenta. So
interesting.
It actually improves blood flow to baby, which is interesting.
I wonder why.
I'm not sure.
Good question, but that's interesting.
Question.
Yeah.
Good question. Now, one of the most common things that I see and that I masked is this idea of it causing long-term back pain, right?
Yes. That is a huge one.
Exactly. Everyone thinks that they're going to have chronic back pain from their epidural. And again, far be it from me to discount someone's personal experience, right? But when we look at the data, there's a Cochrane review from 2018, which is an update from the 2020 or 2011 Cochrane review that we referenced previously. It included data from over 40 trials covering over 11,000 women. And they did not find any difference in the incidence of long-term backache or back pain between people who had an epidural and people who did not have an epidural. So that's a lot of people to be pulling from. And that is, a compelling stat in and of itself. Now, I will say that the Cochrane Review, in full transparency, noted that this is low quality evidence. And the reason for that, in spite of how many people this covered, is just that there's a lot of limitations to study design when we're looking at things that happen in someone's labor.
Yeah.
There's a lot of inconsistency between different studies as we're trying to pull data, a lot of heterogeneity into the ways that things were described and calculated, as well as possible publication bias associated with some of the studies included.
Yeah.
And so, again, it's not to discount anyone's particular circumstance, but I want to alleviate fear that you are necessarily going to have back pain associated with your epidural. Rather, in some cases, back pain can be associated with the musculoskeletal strain of pregnancy, childbirth, and postpartum.
Yeah.
And again, I wouldn't want somebody to feel as though we're saying that their pain doesn't exist because this association is not something that we're able to really demonstrate in the evidence. But rather, I think it's important that when people are describing back pain postpartum, that it's adequately assessed, right?
Yeah.
And that we don't just blame things on the epidural, right?
Yeah.
If you're having pain, there may be a solution, right? Even if it's not caused by the epidural, it could be caused by something else that has a solution to it. And so it's well worth us, turning our minds to the fact that many things can cause back pain afterwards. And that when we look at large numbers, again, we don't necessarily see that people with an epidural or without an epidural have any higher or lower incidence of that.
100%. And I think that, I feel like with the epidurals, of course, I've heard patients say, it felt like I got kicked in the back, like right afterwards. That's kind of what it felt like. Once the epidural was out, they felt like it was just sore or bruised, which is realistic. There was a procedure done to your back. I think that's not like, that's to be expected to a certain extent. But if you're having chronic pain, weeks and weeks after, that's debilitating and affecting your activities of daily living, you should have that checked out.
Well, and again, it should raise a red flag for both patients and for providers, right? That something outside of the epidural is going on.
Exactly.
Right? That there's something else going on here, and that we should be evaluating it appropriately as opposed to just blaming obstetrics in general, right?
Exactly. And I mean, whether it is the epidural or it is something else or a combination of things, we don't know until you have that checked out. And I will say that I think I even experienced this as just a nurse. Like my first few years of nursing, I had terrible back pain, and it was because my core was really weak, and I needed, physio and strengthening exercises in that respect. And when you're pregnant, your core muscles basically are.
Oh, I certainly. Props to the women who work out their whole pregnancies. I became a couch potato.
That didn't happen.
And the most I could do was do like nightly walks with my husband because I was exhausted.
Yeah, you were growing a human. And
I could not.
But you have to also realize that, your body's gone through a lot of changes, delivery too, everything. It is stressful on your body, and and you're gonna probably have some aches and pains that need to be, addressed and with physio and all that kind of stuff. But if they are severe and if they are impacting your life significantly, I encourage you to go get that checked out for sure. But
so before we wrap up, there's one more myth that I see people say all the time and always worry about. And I would love your perspective on it too, because really you're going to be the person who can speak to this, I think, most specifically. But everyone thinks that they can't push effectively with an epidural, and that one of the major advantages to an unmedicated delivery is this idea that you can push better. The truth is, when we look at, again, going back to the evidence, studies show no significant difference between effectiveness in pushing with modern low-dose epidurals, right? So these are not our grandmother's blocks. These are not the ones, this is no twilight delivery. You can often push effectively, even with that sensory block in place. And oftentimes I've also found that some people find it actually easier to focus on instructions when they're not in such severe pain.
Yes.
I will say, the pain of contractions, at least in my own labor, I described it, I feel like afterwards to several friends as all encompassing. And it's hard to really characterize well, I think, until you've explained it.
Yeah.
But I totally get how like during contractions, all I could think about was getting through the contraction.
Yep.
I had no, ability to listen to or participate in anything that was happening outside of that contraction.
Yes. Yeah.
But Sid, you're the one who does most pushing with people, right?
It's kind of one of those things again. It's very patient dependent. I will say, most epidurals, if you have a good epidural that's not, like you said, not super, super, super heavy, you will still be able to feel that pressure. And it's going to be an intense amount of pressure. It's going to feel like a mag truck is coming out of your butthole, truly. Like that's what it feels like. Or at least that's what I've been told. And that is a good sensation to feel, because then you'll be able to know, I got to push there. And I always tell my patients, like, you push like you're having a bowel movement, like you're having the biggest poop you've ever had. So you want to bear down and push into your bum like that. And people are very successful in doing that with epidurals. People are also very successful in doing that without epidurals. Have I had some patients who have not really got the hang of it? Maybe because of the epidural, because they're so numb and they can't feel anything, and they're maybe pushing more in their head than their bum. Yeah, but that can also happen when you're unmedicated too.
Well, this is what I was going to say. It's hard to know, especially if it's someone's first delivery, how they push, how they would have pushed. Like
especially if they haven't done it before.
Yeah, the learning curve is different for everybody, no matter whether you have pain control on board or not with neuraxial analgesia.
And I know there's something called like the fetal ejection reflex that like some people might feel if they are unmedicated. But at the same time, it's you're still able to feel those sensations, I think, to a certain degree with the epidural, and it still be effective pushing. You might need a little bit of extra teaching and a little bit of extra help. But I've had unmedicated primips, so first-time mamas who still need a lot of teaching too.
I have had patients who deliver in 5 minutes with an epidural with their first baby. That's not average. So that is like way faster than average. I've also had people without an epidural deliver push for like 2-3 hours, right?
Yes.
It is so individualized. And I think what's important to keep in mind is that you absolutely can push with an epidural, and your nurse on your floor is going to be well equipped to coach somebody through an epiduralized delivery.
Yeah. And there's different positions that I'm a huge, like, different pushing positions girly. So like there's different positions you can try that might help. There's so many factors that come into play at that particular moment, like the baby's positioning, you know, all that kind of stuff. How strong are your contractions? You know, there's a million factors that you have to consider. So it's hard to just say, if you have an epidural, you're not going to be able to push your baby out. That's not necessarily true. I also know some people who, kind of like you said, they were able to relax enough to actually focus on pushing their baby out with the epidural.
To take in the teaching that you're providing.
To take it in. Because when you're in active labor and you are in that bubble, that birthing bubble, sometimes you can't hear anything. You can't focus, like you said, on anything except for getting through that contraction. So for some people, it is very beneficial to have the epidural. I actually would love to have one of my friends, Kara, the baby nurse. She has actually experienced 2 unmedicated births, and then her last one was with an epidural. And one of the things that she has said was that her birth with the epidural, she was actually able to almost enjoy slightly more because she could take it all in, and it was so calm. And it's just a very different experience. She still says she loved her unmedicated births as well. But it's really fascinating to talk to someone who's experienced both sides of the you know, with her epidural and without, just because there's so many different aspects to consider and pros and cons, and everyone's different, right? So,
and I think that's a nice sort of lesson to cap this off with as well, is that there is no better or worse. Right? There is no medal for an unmedicated delivery at the end. And there is no shame to needing an epidural. Right? Both
or changing your mind.
Or changing your mind as you go through the process, right? Every labor is different. Every parent is different. Every baby is different. And maintaining like a safe, positive environment, whatever that looks like from the perspective of your pain control is ultimately our goal, I think, as providers, and something that is, well, in the interest, I think, of having a positive delivery experience.
Yeah. If you guys could take anything away from this podcast today, it would be to keep an open mind, to do your research ahead of time, ask your questions, familiarize yourself with different pain management techniques. And if you are curious, you can also ask for an anesthesiologist consult ahead of time for some people who do qualify for that. If they have, let's say, like we talked about before, a blood disorder or something else, or potentially severe scoliosis or something that would qualify them for an anesthesiologist consult too. I've seen that before. Ask your questions, be prepared, and just stay open-minded, because you're not going to know what you're going to need until you're actually there and going through it. So.
Yeah. And epidurals are safe.
Yes.
They are effective.
Yep.
And they're
a great tool.
They're a great tool to have in your belt, but they're just one tool.
And also, just when you get the epidural, I think the most important part is to just keep moving. I will say that is to just still change positions, because I feel like a lot of times people blame the epidural, but I feel like it's just like, you just got to move. You got to still stay like moving into different positions so baby can get in that adequate position for delivery. But
tell us your experience.
Yeah. Right? How was your epidural?
Comment, share
your non-epidural
experiences. Exactly. With medicated deliveries, with unmedicated deliveries. Let us know how you felt.
DM us on Instagram at the.push.podcast. And
send us an email at askthepushpod@gmail.com.
Yeah, we'd love to hear from you.
Or comment on any of our platforms.
Yeah. Well, thanks guys for listening. I hope you learned a lot about epidurals.
We will see you next time.
Bye.